welcome to everybody tuning in, either during your lunch break or after your lunch. I'm going to talk about more of like the medical issues related to sports traumatic brain injury and what can happen as a result psychiatrically. Now, the reason I'm interested in this, during my training, I worked at Oregon State University treating college students for counseling and also medication management. That included athletes, and also in my current practice, I've had the opportunity to work with post-concussive athletes as well. Okay, so kind of talk about several things. Some epidemiology and stats, quick brain anatomy lesson, this evolving definition of what is a concussion, some risk factors that predispose to some of these persisting psychiatric symptoms, some of the most common symptoms, and also syndromes. That's talked about a little bit about that earlier, which was a great overview. Specifics about post-concussive syndrome, traumatic encephalopathy, and also, most importantly, prevention. Okay, so seen it in the media: Ray Easterling, Dave Durison, Junior Seau, and more recently Paul Oliver. These are all former NFL athletes, football players who committed suicide as a result of traumatic encephalopathy, and that was diagnosed post-mortem, so after they died. But I'm going to talk about specifically what is this underlying issue that's leading them to experience these symptoms. So some stats and some epidemiology. So between 1.7 and 3 million sports and recreationally related concussions happen every year, so that's a lot. On average, 300,000 are football related. There was a review done from 1985 to 2000 that found that ice hockey and rugby had the highest incidence of concussion in high school and college and amateur athletes. Soccer had the lowest. Now keep in mind there's various studies out there. They're all different. 1 in 10 athletes in high school who play contact sports, including soccer and lacrosse, will suffer a concussion this year. So that's a lot, 1 in 10. In the NFL, of 1,063 retired players, 2% have been diagnosed with dementia at the age of 70 years. That doesn't seem like that much, but compared to the general population, that's 19 times that rate. And this is important too, because 90% of concussions don't involve loss of consciousness, so it's not that obvious. So we rely on what they tell us and what they're experiencing after they're hit. And it wasn't until April 2010 when the first active college athlete was found to have chronic traumatic encephalopathy. That was offensive lineman Owen Thomas of the University of Pennsylvania. Okay, so what is a concussion? If you think about it, it's been evolving. This is not anything new that goes back to when boxers were getting hit. This goes back to 16th, 18th century, and there's documentation of it. So it's a rapidly changing definition. So in the 18th century, it was termed commotio cerebri, and it's important to keep in mind what these definitions are and why it's evolved. But back then, it was said to occur due to traceless disturbances, which isn't true currently, that produce momentary functional impairment without any damage to brain tissue, which we're finding out is not true. For decades, even after that, you would look into your standard neurology textbook, which is what medical professionals look at, and it includes stuff like the following quote. It would say a concussion was where a usual patient loses consciousness briefly, think it's not long term, then they'll soon recover, and thereafter is without symptoms. So that pretty much minimizes the impact, utilizing those words. And then also theories at that time viewed concussion as benign, and like I said, they minimized the impact of the behavioral symptoms that can occur as a result of getting hit. So I bolded it in yellow because there was a series of articles published in 1961 that said concussions were nothing more than accident neuroses. When you think, what is neuroses? You think neurotic, and you think it's just in their head. It's not medical. Also, it was because there was a lot of lawsuits involved with these injuries. They called it compensation neuroses. And then you'll also find that a lot of the literature and even these big organizations use the word concussion and mild traumatic brain injury interchangeably. When you think mild, you think it doesn't cause that much damage. So that's kind of where, it wasn't viewed as something very severe and long-lasting. So, brief anatomy lesson. Try not to make it so boring. But it's important to know different parts of the brain that could be affected and why we experience certain symptoms. So we have the frontal lobe right there. That involves, if it's injured, difficulty with switching tasks, organization, planning, pretty much all these executive functions and things you need to stay on task, especially as a college student. Could cause agitation and poor impulse control, and also apathy. Next, we have the temporal lobe. If that part's affected, it causes memory disturbance, and also these ups and downs in your mood, so a lot of emotional fluctuations. Next, we have the basal ganglia. If that's injured and affected, it can cause some Parkinson's disease type symptoms. So that can involve tremor, which if you're an athlete, you don't want to have tremor, and also slowness in movement, in addition to depression. And the last part, this is the limbic area. If that's affected, it could cause somatic type symptoms that involves, irritability, impulsiveness, thoughtlessness, and also some psychotic symptoms. So this is kind of just like a quick, concussion video about what happens. A quick just kind of concussion video that talks about the fluidity of the brain. I don't think it's showing up. Oh, there we go. Okay, so what happens? See, the brain's very fluid. It's like jello. When you have blunt trauma to the head, it'll move back and forth. So it's not like a skull fracture. Your brain is moving, it's accelerating, decelerating after that hit. So see, it kind of has rotation. As each time that you do that, this produces damage chemically, and also this can lead to buildup of some toxic proteins in your brain, which will lead to long-term impairments. So specifically what happens is these are axons, and these are kind of these they connect and allow communication in your brain. After a hit, these can shear as a result of that, and then that'll cause them to swell. What's your brain going to do? When they're swelling, it's kind of like if you sprain your ankle. You don't want there to be continuous swelling, so you're going to try and divert that blood flow away from it because you don't want your brain to swell. So you have tearing of small blood vessels that try and compensate for that. So there's a lot going on in your brain at that time. The hope is that they'll recover enough that it doesn't lead to further damage, which is the secondary injury, and that's what you're hoping to avoid in second impact syndrome, and also what can lead to persisting symptoms. So this is the inflammation phase. This is what you don't want to occur. You can see, that points at little toxic proteins that build up in the brain, and that can lead, depending on where it is, that can lead to long-term damage. Okay, so what are some common hits associated with concussion? Basically any hit to the head. But what's more commonly, in football, it's basically the backs, quarterbacks, also wide receivers, defensive secondaries who receive face mask impact at an oblique angle, like so. Hockey, any blow to the head also. And then also in Taekwondo, roundhouse kick to the temporal region. Okay, so what are some risk factors? Well, the greatest risk factor is if you've had a previous concussion. Obviously, you hear a lot of players, they would have had maybe like 3 or more in one season, or more than that. It's been found to have 2 to 5.8 times higher risk of sustaining another concussion. Okay, so what are some common psychiatric symptoms? So, depression. And I wanted to show a comparison. Basically, the one on the right, the blue, that shows, what percentage of those who experience traumatic brain injury versus the general population in green. You can see 25% versus 17%, so it's a lot higher incidence of depression. And it's been been shown that estimated that 25 to 60% will develop a depressive episode within 8 years. There's also anxiety. They estimate that 24% will develop a new anxiety disorder if they've had brain injury. So you see how much higher it is compared to the one in green, which is the general population. So there's definitely a lot more prevalence. Substance use, and that was talked about earlier. So substance use disorders is higher as well compared to the general population at 22% in those who've been injured versus 15%. Okay, so there's some differences in males and females. Anybody who's been injured is prone to experience any type of psychiatric symptom, but in males it's been found that they might exhibit more aggression or ADHD type symptoms, which I've also seen in my practice. Females tend to present more as having depression or more emotional ups and downs. How long do concussion symptoms usually last? Well, most studies report that 80 to 90% of athletes, their symptoms will resolve over time, within 7 days, and that would be ideal. But then for those percent who go on to experience progressive symptoms, if it's not going away within 7 days or even more than that, your prognosis is a little bit more poor. But there are studies that vary too. Some show that there's not much change in prognosis. Some show, yes, you're not gonna do so well. So post-concussion syndrome. So this is another. A lot of these definitions that remain in areas, but this is basically a collection of symptoms, and I'll show a diagram. Duration is longer because there's a whole cluster of symptoms, but it's generally more than 3 weeks. So you'll have maybe some cognitive symptoms, so that'll involve memory issues and concentration, and then you can also have the physical symptoms, and that's usually pretty common too, like the headaches and dizziness. And then you could have the mood symptoms too, like the anxiety or the aggression and the depression. And also common is the sleep problems. So those who experience post-concussive syndrome, it's a whole variety of symptoms. So I wanted to talk a little bit about traumatic encephalopathy as well. So this is also an evolving concept. Going to 1928 when it was referred to as punch drunk, when they observed that boxers were having, rather than after the direct hit, they were exhibiting persisting symptoms. And we don't have to go over the rest, but it kind of shows how the terms and what the nomenclature has changed over time. But the first NFL football-related case of this was first neuropathologically confirmed in 2009. So Dr. Victorov, he's one of the neuropsychiatrists that I've worked with, but he did a systematic review and found 97 historical cases. Now, keep in mind, there's no current, diagnosis criteria. It hasn't been laid out yet as to this is what traumatic encephalopathy is. But he searched cases that are documented going back to 1928 of those who suffered a hit and experienced progressive symptoms. Found 97 that met criteria. So on average, he found amongst that sample, symptoms occurred up to 6 years. So it was a delayed onset after they had ended their career. So, you could already be retired, but then you could suddenly find that you're experiencing these symptoms, and you wouldn't immediately connect it with the injury, but it definitely could occur. Average duration of the sportsman's career who experience these symptoms, they play long term, so it's approximately 15 years. The most common neurologic symptoms that involve difficulty with speech, poor coordination, disordered walking. The most common psychiatric symptoms, memory loss, and this course of memory loss is like dementia. It's pretty quick, and it's unfortunate because you'll see it occur in 20 or 30-year-olds. Aggression and mood disorder. Now, amongst those symptoms, the most difficult to control behaviorally and manage is the aggression, because a lot of times you'll hear that there's an athlete who's usually really mild-mannered and has a calm and laid-back personality, you'll find that they're struggling with aggression, and it's really hard to get under control. So more kind of specifics about, what's going on with the brain with traumatic encephalopathy. So it's usually involved following multiple concussions, but they say that there's been cases reported after a single blow. But again, diagnosing a concussion is pretty difficult. So who knows? Maybe they've had more over time. Compared to the immediate concussion symptoms that you experience after the hit, or even post-concussion syndrome, the difference with traumatic encephalopathy is that these last longer. These are persistent. These are progressive. They could continue to get worse. And then again, going back to that slide, it's kind of like that secondary damage that can occur in the brain with the buildup of the proteins, but instead it's more diffuse. So it's not just that an actual model would be more protein deposits. Okay, I wanted to skip this, but basically it's been found, it's there. But I want to point out that there is an increased risk genetically, and that's with the ApoE. It's on the very bottom, but that's a risk factor for Alzheimer's disease, and they're also connecting that with, why are certain athletes experiencing this progressive course of dementia so early? And they're finding that's most likely linked to that. Maybe there's something genetically. Okay, so what's the treatment approach for behavioral complications of traumatic brain injury? So it's important that they have a neurologic exam, so they see the neurologist. They have a psychiatric exam and see a psychiatrist or mental health professionals. Some neurobehavioral testing, so we could see and Whitney referred to it earlier, it would be nice if they could test each athlete beforehand, just show what their concentration is and their baseline levels are. But they don't do that. But it would be good to do testing to kind of see how much of impairment there is. There is some medications that could treat symptomatically, but obviously not stop progression, at least we don't know right now. Prevention is really important, and also emphasizing return to play guidelines. And I highlighted patient education. I'll talk about why. Okay, so medications. So we do have medications out there. We pretty much use similar medications that we use to treat aggression, some concentration problems, affective, meaning like mood disorders, anxiety, and even psychotic symptoms. So we could treat symptomatically. But right now, no current treatment standards exist. So some studies will say, that they don't have enough evidence to say this medication is really going to help someone with traumatic brain injury target their anxiety. There's really no guidelines. It's more kind of using your clinical opinion. Okay, so prevention is really important. Prevention of the second impact syndrome. So on second impact, that's kind of like that secondary insult that I showed earlier. That's where, our body's way of defending against that swelling, which we can usually do upon the first part of the injury. When you're hit again and you're put back into play too early before your symptoms resolve, you are at high risk of second impact syndrome, which could be fatal. And that would cause even more diffuse swelling. It's not just those little parts of your brain, it is more diffuse, and that could lead to more pressure, pushing your brain into places it's not supposed to be, cutting off the blood supply, and that could be fatal and lead to death, which has occurred. So abstaining from sports and brain rest to avoid re-injury and any stress factors. They even emphasize don't text, don't use your brain. That's really important. Okay, I'm not going to go over that. That's general return to play guidelines. So again, I'm emphasizing education, and that's one of the reasons why I'm here. Because we go, for the most part, we could observe, and obviously, it's obvious if they've been hit and if they're dizzy and if they're struggling. So symptomatically, we go based on what the athlete will report to us if they're experiencing after a hit. So the top part, there were studies done on both adults and children. One group received early intervention after getting hit, explained these are the consequences that can happen if you don't tell us you're having these symptoms and get appropriate rest. And they found that the group who got the education were more likely to report less symptoms at 3 months versus those who didn't get education. So the fact that they were able to report it, they were able to prevent further progression of their symptoms. And also for high school soccer athletes, they did a survey and found that if they educated them and told them about concussions, that 72% were more willing to report their symptoms compared to 36% of players who didn't get that education. So it's important that they're informed. Contact info if anybody has any questions. I don't know if we have time for questions now.
We've got time.
Yeah.
Any questions? Yeah.
Sorry, 2 questions. Try to articulate them well. So when you showed the slide that indicated that for most people it's about 7 days before their symptoms resolve. Either in your practice or in the research, do you feel like that all of the symptoms resolve at 7 days? Are they still taking symptoms? Are there other healing processes that may need to be occurring? And is the end of symptoms really where the protocol should be?
Mm-hmm. Yeah, I mean, they could extend it, but really it is, they can return to play once all those symptoms are completely resolved. Yes. So, and they even did studies on kids after the fact and even found that, average time it took them to return to school even after it hit was 7 days. So, it is after complete resolution of the symptoms.
And the second part of that is knowing what you know about the tearing of the blood vessels in the brain, and I'm thinking more from an orthopedic standpoint. So the stages of healing with muscles and ligaments.
Mm-hmm.
Stages of healing tells us that there's a swelling for 2-3 days, and then the body's processes continue another 4 to 6 weeks.
Mm-hmm.
And does the healing occur in the brain at that same rate in terms of the healing of the blood vessels? Does it sort of the initial swelling subsides around the first 3 to 4 days, but is that continual healing really going on? That second stage of healing, is that really persisting again for that next 4 to 6 weeks, or does it have a more rapid? That second stage is a little more rapid.
To be honest, I'm not sure. Yeah, I don't know exactly how long it takes.
Because I guess I'm trying to correlate it back to thinking about an ankle sprain. So an athlete comes in and we're splashing blue, and when it starts to feel better and the swelling subsides, but we know that there's still healing that's occurring, and that if they go back too soon, they're at risk for re-injuring because it hasn't fully healed.
Yeah.
And so I'm wondering if we can apply that same pattern of healing to the brain, or if the way that the neuromuscular tissue regenerates if it or heals itself.
Yeah.
If it's a different pace.
Yeah. That would be more ideal to extend beyond even the regular 7 days. But honestly, physiologically, I don't know exactly how long. But I think it would be better to wait, honestly.